Hello, welcome to your online lecture for the course Pathophysiology 1. In today's lecture, we're continuing on with our topic of cancer. We've already discussed the epidemiology of cancer in Canada. We spoke about some important terms in understanding cancer, and we spoke about the biology of cancer cells. In today's lecture, we're covering invasion and metastasis, clinical manifestations, and risk factors in cancer. So starting off with normal epithelial tissue before we actually get into invasion and metastasis. So in this first image here, you can see normal epithelial tissue, which is here, and then the connective tissue that underlies it. And the cells look normal, they're uniform, they become flatter as they move closer to the surface. But in the second image here, when we look at low-grade intraepithelial neoplasia, you can see that many changes have occurred when you compare it to the normal epithelial tissue. You can see also that the connective tissue is still considered to be normal, but we have a lot of changes going on up here, and you can see that at good third or more of the epithelial tissue has started to change. You can see that the surface above has taken on this humped appearance. It's no longer flat as it was in normal epithelial tissue. You can see that these cells are starting to look very different than the normal cells, and because they look different, they really are different, and the different structure that they take on may not allow them to carry out the normal function that these cells should be able to execute. But these cells here, for the most part, are still considered normal, and they can still carry on their normal function. Now, in the third example of high-grade intraepithelial neoplasia, this is where major changes are seen, and that's just very evident by looking at the comparison between the two. You can see that the connective tissue is still considered to be normal. There's still that boundary between the changes in the epithelial tissue and the connective tissue beneath it, so that basement membrane then has not been penetrated. This type of cancer is called carcinoma in situ, meaning that it's cancer in place, and the entire normal epithelial tissue has changed and has been replaced by cancer, but it's considered in place and has not invaded. But the fourth example here is called invasive carcinoma, and this is where cancer is no longer in place and it is penetrating the basement membrane. It's invading the connective tissue beneath it and disrupting it as well. And so this is where we have to now get into the topic of metastasis, because after invasion, metastasis can occur. This is a PET scan in this image that you can see on the left of the screen in front of you. And with this PET scan, it's highlighting the use of glucose in different areas of the body. And so the darker regions are tissues that use a lot of glucose, and this would be maybe normally restricted to places like the brain, the heart, and the bladder, where there is a lot of glucose activity. But as you can see from this image, you can see darker areas all throughout, just scattered throughout. And this is an example of metastasis. And in this case, this individual had a type of lung cancer that was removed, and then 5 years later went back in for a scan, and it was evident that it had spread to the bone, the lymph nodes, as well as the liver. So the primary cancer, even though this person has cancer scattered throughout her body now, the primary cancer was the lungs. In other words, where did the cancer originate? In this case, it originated in the lungs. And from there, once it invades, it has the ability to metastasize and spread. And so then the secondary cancer, in this case, is in the bone, the lymph nodes, and the liver. And of course, the primary cancer in other cases could be the liver, it could be the bone, and the secondary cancer could be the lungs. But just remember that primary refers to where it originates, and secondary involves metastasis. In this image on the right, it demonstrates the sequential process of metastasis. And so you can see here, if these represent normal cells, you can see there's transformation occurring. Cells are becoming abnormal. In addition, we know the term angiogenesis is the generation or formation of new blood vessels, and we also know that cancer has that ability to secrete its own growth factors, secrete its own factors that allow for it to really tap into our blood supply and feed itself. Motility and invasion. The entrance of cancer cells into capillaries, into lymphatics, into vessels within our body is the process called intravasation. And once they get into our vascular supply, this can become very concerning. Entering our circulation, the ability to spread to other places, but in addition, they have the ability to form what's called an embolus. And an embolus is really any substance that can dislodge or become part of the vascular supply that can eventually, as it's moving through blood vessels, get to smaller and smaller and smaller blood vessels and then get stuck. And it can cause an infarction or ischemia and then infarction to those tissues where blood can't get past that embolus. And so cancer cells themselves can act as an embolus. And so an infarct can happen, or ischemia can happen in tissues such as the lungs, for example. The cancerous cells can become arrested within capillary beds. And what this means is that they start to really get stuck to the blood vessel wall. And when they get stuck in this place, then they have the ability to migrate out at that area. And when they migrate out at that area, they can spread to another environment where they can sort of set up shop and continue to grow. And that's provided that the tissue that they leave is an environment that the tissue that they enter is an environment that the cancer can grow. It's optimal for cancer growth. And so that process of leaving the blood vessels is extravasation and into an organ. And then you can see in this image here, cancer spreading to the lungs. This image here demonstrates some of the common areas of metastases, so where cancer can spread from a primary location to other areas. So examples we have here are the brain and cerebrospinal fluid, the lungs, the liver, the adrenal glands, so they sit on top of the kidneys, and bone. And the corresponding images over here show you that, for example, this is what if cancer spreads to bone, so the spine or the vertebral column is an example of where cancer can spread, and the femur here is another example. But you can see in this image cancer that's spread to the bone. We also have the brain, and so you can see different regions throughout here that look abnormal where cancer has spread. This is representing the liver, and you can probably tell right away that it doesn't look normal. And then another example here are the adrenal glands. Remember, these sit on top of the kidneys, so cancer is spreading to the adrenal glands. And then the lungs, you can see various areas throughout here that look abnormal throughout the lungs. And this is because of metastasis. And the thing with metastasis, now let's actually go back to primary cancer. So a primary cancer, they will oftentimes have one nodule. So if you can treat the primary cancer before it's actually spread, it tends to be a little bit easier for removal. But secondary cancers tend to have more than one nodule present, and you can see that here, they're everywhere. So it makes it very difficult to treat, very difficult to remove, because there's just so much of it. And cancer cells, remember, they have many advantages over normal cells. And remember that they produce their own growth factors. They use up a ton of glucose in the body. They can use anaerobic glycolysis. They just have this amazing ability to have advantage over normal tissues. They also can destroy normal tissue found within the area, depriving it of what it needs to survive, for instance, glucose. Or it could just obstruct blood flow to those normal healthy tissues or normal healthy cells. And this leads to an overall increased chance of mortality once these individuals have metastasis. So now we'll talk about clinical manifestations, and we'll also speak about the different staging in cancer. This slide talks about a method of classifying a tumor based on the tumor itself, based on the involvement of nodes or lymph nodes, and the more lymph nodes, the poorer the prognosis generally, and the evidence of metastases. And so this type of staging will allow allow healthcare providers to determine the prognosis of these individuals and then the necessary interventions. So let's have a look at each of them to see what they mean. T, of course, stands for tumor. In the case of T0, that just means that there is no presence of a tumor. So this is healthy organ, healthy tissue. You can see that once you get to T1, there's evidence of, and this I should make note of, is breast cancer. We're talking about breast cancer in this example, but it can be applied to other cancers as well. So in this case, the cancer is about 2 centimeters or less than 2 centimeters in terms of size. T2 represents greater than 2 centimeters, so 2 to 5 centimeters. And then T3 is where the skin or the chest wall or invasion has occurred. Now on to lymph nodes. Of course, N0 represents no lymph node involvement, but then once we start getting lymph node involvement, this becomes more concerning. So in the case of breast cancer, N1 is the presence of lymph node involvement, but they're considered to be mobile nodes that are involved. Whereas N2, fixed nodes involved, and you can see there's quite a few different lymph nodes that are involved. With metastases, talking about the extent of metastases, common locations of spread being bone, lung, and liver when we're talking about breast cancer. And with metastases and M1, we're talking about no metastases has occurred, or M0, but with M1, this demonstrates that metastases has happened, so in this case, the liver. But with M2, there's suspected metastases, so something's going on in various different locations throughout the body. I'll also talk for a few minutes now about the different stages of cancer. And cancer can be staged as stage 1 to stage 4. So stage 1, stage 2, stage 3, stage 4. In stage 1, oftentimes what you'll have is either T1 or T2, so variable size, somewhere between maybe 2 and 5 centimeters with stage 1. But no presence of lymph nodes in stage 1. And no spread. So this is telling us that in stage 1 cancer, it's very local, and that's key. With stage 2, looking at probably tumor size 3, where you're into invasion, and nodes, probably 1, but 0 for metastasis, and that's a key feature there. Still no spread. We're still local. Spread to local lymph nodes, but still local, not spread to other organs. Stage 3, we're looking at anywhere here for size, but now what's important is that we're into N2, where you're getting multiple lymph nodes, distant lymph nodes involved, but still no metastasis. So other organs are not affected. But with stage 4, this is where we're bringing in M1 or M2. In any case, there's been spread to other organs. If it's the case of breast cancer, there could be spread evident in the liver or the lungs or in bone, but the key is metastasis to other organs. So we can say that in stage 4, many lymph nodes involved. The cancer has likely spread then in this case to other organs, such as the lungs, liver, and vertebrae, and then a poor prognosis accompanies this. Let's speak about some of the common clinical manifestations that exist with cancer. Pain is certainly one of them, and pain can be neuropathic. And what that means is really nerve compression. So a nerve is compressed and it causes pain because of it. And what's it compressed by? Well, likely the tumor. And this type of pain is usually not relieved by medications such as Advil that somebody might take if they're experiencing pain. And this pain is usually constant and persistent. And if somebody might have pain in one position, sometimes changing to another position is helpful, but usually with pain that's caused by cancer, change in position is not usually helpful. In addition, let's say somebody has back pain and they go to see a healthcare provider that is working on their back, trying to rehabilitate their back. And these people are not responding to care. Cancer that has spread to the bones, for example, won't allow for therapies to be very, very helpful, physical therapies to be helpful. Fatigue, usually this comes on very suddenly and it's quite excessive, and we'll bring fatigue up again in a moment. Cachexia refers to the sudden and excessive loss of weight. And we can say that this type of weight loss is otherwise unexplained. So it's not, if somebody loses 10 pounds in a month, but they haven't changed their diet, they haven't changed, they've been the same weight for most of their life, they haven't started exercising, nothing else explains it, then this sudden weight loss should be considered a red flag. And it's really because cancer is taking over the metabolic processes in the body. We know that cancer uses a lot of glucose to produce its energy, and it's depriving the body then of its normal glucose supplies. Anemia can occur, and this actually can lead to fatigue if you're anemic. So a reduction in red blood cells. There can also be a reduction in white blood cells, referred to as leukopenia, as well as a reduction in thrombocytopenia. So this is would be a reduction in the amount of platelets. And the reason for this, so remember, all blood cells are produced in bone marrow, and with some cancers, bone marrow cannot function as it's supposed to. And then infection. Infection is usually related to leukopenia because remember that white blood cells are hugely involved in our immunity, and if they're very low, then these individuals are more likely to acquire infections that they would otherwise be able to fight off. On this slide, we'll talk about what's called paraneoplastic syndromes. A syndrome is really a group of symptoms that tend to consistently occur together, or you could say it's a condition characterized by a set of associated symptoms. But paraneoplastic syndrome is a disease or symptom that is the consequence of cancer, but it's not due to the presence of local cancer cells. Okay, so not caused by direct effects of the tumor mass. And there are many different syndromes that exist, and this slide is only covering some of them. So let's start with hypercalcemia. Calcemia is referring to calcium, hyper is referring to lots of, so this is, and then emia refers to the blood, so this is excess calcium in the blood. Now, parathyroid hormone, if you remember, is a hormone produced by the parathyroid glands that normally helps maintain blood calcium levels by putting more calcium into the blood when blood calcium levels go down. But if there's too much secretion of parathyroid hormone, then there'll be too much calcium put in the blood. Some cancers can actually release or produce what's called parathyroid hormone-related protein. So it can be occasionally released by certain cancer cells, and it's actually more common in breast cancer as well as lung cancer. And so when this hormone is released in excess, as I already mentioned, calcium levels are far too high, and what can be seen is, well, anything that's related to too much calcium in the blood and not enough in maybe other areas is decreased neuromuscular excitability, muscle weakness, kidney stones, constipation, heart block. The calcium is also going to be taken from bones as well. Bones are going to be broken down to put more calcium into the blood. So all around, not good for overall body function. Another example is hypoglycemia. So this is low glucose levels in the blood. Liver cancer can release an insulin-like substance into the blood. Now recall that insulin is a hormone that's produced by the pancreas that is released when blood glucose levels rise. So after you've just eaten a meal, insulin is released in order to promote the uptake of that glucose in your blood into cells, so encouraging glucose uptake by cells in your body. And then of course the cells will use that glucose to produce ATP. But in the case of liver cancer and this increased insulin-like substance, we end up taking too much sugar out of the blood and having low sugar levels. Another example is polycythemia. This is a high level of red blood cells. So lots and lots of red blood cells compared to normal. So think back to normal anatomy and recall that normally the kidney will release a hormone called erythropoietin, or EPO for short. And this is released, this hormone, when there's a need to increase red blood cell production within red bone marrow. So let's say blood oxygen is lower than it should be. A response will be that the kidney will release erythropoietin, which will stimulate the bone marrow to produce more red blood cells, and then more red blood cells means more hemoglobin, which means more oxygen can be carried. But in renal or even what we know of as kidney cancer, there's this increase in production in red blood cells. So too many red blood cells in the blood, and this can be dangerous. It can actually lead to thrombus formation. A thrombus is a clot. So if the blood, it's almost becoming too viscous, too thick, and it can lead to a stroke, among other conditions. And that actually leads me into venous thrombosis. You can have a venous thrombosis that forms because of polycythemia. So there's too many red blood cells within the blood, and it can lead to clotting within the venous system. And then these clots can get stuck in certain areas and block certain areas, preventing proper blood flow, which we know is called ischemia, which could then lead to either hypoxia or anoxia, depending on the situation. And that would be applicable in our arterial system. But when it comes to our venous system, if clots dislodge and travel to, for instance, the lungs, it can cause what's called a pulmonary embolism. And as I said, those were just a few examples. There are many. We'll talk now about tumor markers. There are specific biochemical markers of tumors that have demonstrated to be helpful in the diagnosis of cancer. These tumor markers are produced by cancer cells, but they're also produced by benign tumor cells as well. And they can be found in various areas such as the blood, the cerebral spinal fluid. They can be detected in the urine as well. And up on the screen are some common examples. The first example that we'll talk about is called carcinoembryonic antigen, or CEA. And this is a protein that's normally found in very low levels within the blood of adults. And when this level goes up, it could potentially indicate colon cancer. Okay, so CEA blood level may be increased in certain types of cancer, as well as benign conditions, but this test is most commonly used for colorectal cancer or colon cancer. Another example is alpha-fetoprotein. This is used as a tumor marker to help detect and diagnose cancers of the liver, the testes, as well as the ovaries. Prostate-specific antigen. This is secreted into the blood by prostate tumors, but it's important to know that the majority of men that have elevated PSA levels don't actually have prostate cancer upon biopsy. And then we have human chorionic gonadotropin hormone. Increased levels of this hormone we know are present when women are pregnant, but it could indicate that there is a potential placental tumor depending on the levels which follow a particular trend throughout pregnancies. Adrenocorticotropic hormone. This is a tumor or a hormone that could potentially indicate a tumor of the pituitary gland, such as, for example, Cushing's disease, but that's not usually cancerous. So many different examples here, and tumor markers can be used in a few different ways. One, it can help to screen and identify individuals that are at high risk for cancer. It could be used to help diagnose a specific tumor. So let's say individuals that have these particular clinical manifestations that relate to their tumor, having these markers can help with diagnoses. And it also helps to follow the clinical course of the tumor, so you can observe changes in these tumor markers throughout time, maybe throughout treatments, maybe comparing before and after the course or during the course of certain therapies. This slide summarizes a lot of the modifiable and non-modifiable, really risk factors more than causes of cancer. And the difference between modifiable and non-modifiable is important because there's certain things that are out of our control, and there are many things that are in our control, things that we can choose to do or not to do. For instance, non-modifiable is menopause. Can't choose not to enter menopause if you're still alive. Then there's certain jobs where you might be exposed to certain things that could cause cancer, considered carcinogenic, and we'll talk about that shortly. And maybe you don't have much of a choice over this. Maybe it's a job that you have to work because you have to support your family. But things we have control over: sun exposure, so much control over that. Choosing to smoke, choosing how much alcohol to consume, choosing what we eat or don't eat. Controlling our weight, even though sometimes our weight is not entirely in our control, we do have some control over it based on things such as exercise and the foods that we consume. Infections, we can sometimes put ourselves at risk of being exposed to certain infections that could potentially cause cancer, but we also have control over certain exposures. So things that we don't have that we do have control over rather might be our exposure to HPV, which we know could potentially cause cancer. Even HIV. These viruses, we have a little bit more of control over exposure, but it depends on how we were exposed to it. Ionizing radiation, an example here would be X-ray exposure. Are you constantly getting X-rays? Do you work in a job that requires you to be exposed to ionizing radiation? So many different examples here of modifiable and non-modifiable risk factors that could potentially predispose someone to the development of cancer. A few terms to go through. Carcinogen, I mentioned this on the last slide. This is any substance that could cause cancer. And carcinogens can be in the form of environmental factors and lifestyle factors, for example. So with environment, there's occupational things that we're exposed to. There are individuals that have to work outside in the sun on a daily basis, and because of that could predispose them to the development of skin cancer. Those that work in ionizing radiation, maybe an X-ray technologist, for example, if they're not taking proper precautions. Non-occupational, exposure to pesticides, air pollution from car exhaust, non-occupational. But with lifestyle factors, we spoke about this quite a bit on the previous slide, that they're modifiable or non-modifiable, and the list here, we've already gone through these examples. And then there's genetic and epigenetic factors that can contribute to the development of cancer. So there's genetic, which is determined by your DNA structure, but then there's epigenetic. And epigenetics it's the study of heritable changes in gene expression, but it doesn't involve changes to the underlying DNA sequence. So there ends up being this change in phenotype, so the what physically shows in that individual without actually a change in the genotype itself. And so this is epigenetics, which it's almost like you can have you can have something that is expressed in certain conditions. So again, not determined by DNA structure, but instead by gene expression, which ends up changing the phenotype or how it's physically displayed. And on this final slide here, we'll just go over the basics. You don't need to know all of the details here, but what I wanted to show you here is that on one side of the image, you can see pro-cancer effects and then anti-cancer effects. And we start here with a normal cell, and then at the bottom we have one that has accumulated so much damage to the DNA and mutations that it has the potential to become cancer. But what's important to know is this is something that happens over the course of time. And it can start with what you're exposed to when you're in utero as a fetus, whether it's an infection that the mom has, some sort of illness. It could be restricted fetal growth. Maybe there's not enough nutrients available to the baby. Maybe the mother was exposed to something that she didn't realize at the time, but in any event, it can contribute to changes in that child's genetics. Body composition, such as obesity, also contributes. Cell proliferation, things that we're exposed to in our environment and non-environmental. DNA damage happens more frequently than you might think, but our body has this built-in mechanism to repair it usually. But when our DNA repair mechanism fails, then this damaged DNA can replicate. And failed apoptosis. We have this system in place where if DNA can't be repaired, then it will undergo programmed cell death to avoid replication. But when apoptosis fails and then you get a cell that should not be reproducing that is, then we have to be concerned that it may now have cancer potential. So once again, You don't need to know all of the details on this slide, but just have an understanding of the general progression. That's the end of today's lecture. Thank you for listening.